Thank you so much for that generous introduction. So most of my job has been done by Dr. Amit Gupta already. So I'll be just giving passing references of what we need to know. Now, we know that the oldest person who has lived for 122 years. So what was the secret of his long life? Number one, disease-free relatively. And therefore, with the advancing science technologies, we can expect to outlive our grandparents' ages way back in the 1900s or the early 2000s. Obviously, heredity, environment, lifestyle does contribute, but hormones do play a major role. So aging obviously causes functional changes in certain cells. Their multiplication slows down, apoptosis increases, stem cells may become inactive. Aging also changes our responses to stresses of the environment, like the UV light, excessive heat, toxins, and of course, poor nutrition. What determines how we age? Number one is chronology. That is the number of years we've been actually alive. The second is the biological age, which means the physiological processes along with aging, such as loss of muscle strength, endurance, disease resistance going down, skin wrinkling, loss of collagen. Psychological age. So, how old do you think? So, I have ample gray hair, but tell you what, I'm still very, very young. I'm not touched 50. Anyways, and of course, social age. So, the way you mingle, the way you interact with people. So, of the forementioned, biological and psychological are the ones which are most important, and these are the ones over which we can exert maximal control with our diet, exercise, avoiding of smoking, excess alcohol, and other unhealthy activities like sedentary lifestyle. So, what happens therein? This is the cell, and there is DNA damage, shortening of telomere, and mitochondrial dysfunction. All of this culminates in stem cell exhaustion, culminates in tissue regeneration as a decrease. So in the aging cell, there may be a hormone imbalance, altered gene expression, so on and so forth, which is mitigated by the nuclear factor kappa beta signal cascade. So I'll be going into these one by one. So hormones, aging causes changes in hormonal axis. We know that. Concomitant diseases and polypharmacy do not help matters at all. And there may be problems, for example, in electrolytes, which may, the fall may be so gradual that a patient with severe hyponatremia may first time present up with seizures. This is just to give you an example. So what happens during aging? First of all, prolactin. Now, this is a hormone from the pituitary, and apparently what we know is that prolactin only causes milk secretion, nothing else. But what we don't know is it's a pleasing hormone. So a high prolactin would actually keep us socially healthy, would keep us more cheerful, which would mean a lesser stress life, and therefore the cascade of stress might not set in. Also, we need to understand that prolactin activates thymocytes, which are a mediator of cell-mediated immunity. So a higher prolactin would mean a better stress-free life, and it would also mean better immunity. The deficiency of prolactin, I'm not aware of any replacement therapies, but a higher prolactin may help. Let me also tell at the juncture that high prolactin, contrary to popular belief, does not cause gynecomastia. Galactorrhea is fine, but it does not cause gynecomastia. Growth hormone. Now, we know that the GHRH pulse is reduced, frequency is reduced, and thereby the GH amplitude is also reduced in the elderly. To exercise, to sleep, all of that, the GH stimulation does not happen. But as nature has it, insulin-induced hypoglycemia response to GH is maintained intact. And that is the beauty of human physiology. The fact of the matter is that GH has some ambiguity. A low GH level is accompanied with a good survival, enhanced survival, lack of frailty in mice. However, GH deficiency does just the opposite in human beings. And obviously, our concerns is human. So lack of GH deficiency may cause osteoporosis, loss of muscle mass, hypoglycemias, so on and so forth. Thyroid disease. So it is twice as common in the elderly as in young. Dr. Amit has dealt about it in great detail. Suffice to say that as one ages, the anti-TPO antibodies increase, the TSH increases. This, in fact, is a compensatory mechanism. TSH increases because there is lack or a decreased basal metabolic rate. The conversion of T4 to T3 also decreases. As he outlined brilliantly, that in the youngsters, subclinical hypothyroidism may entail a greater mortality, while in those above 75 or even 80 years of age, this may be protective. Low TSH, well, can cause atrial fibrillation in the elderly, even in the absence of loss of weight, exophthalmos, so on and so forth. So the treatment threshold for low TSH correction should be high. So by now we have learned that a higher prolactin and a higher TSH level, they may be markers of good and successful aging from the endocrine standpoint. Adrenal function. Now, first of all, the cortex. So cortisol levels, what happens is that the pulses are the same, but in the evening and the morning, the difference or the circadian or the dynamic variation is not as pronounced in the elderly as in the young. Also, the peak happens 2 to 3 hours earlier in the elderly as compared to the young, so that technically and practically the levels are somewhat lower in the elderly. We know that adrenal cortex secretes cortisol, which is a hormone of stress. So these people may not be able to withstand stress better, but we must understand that thankfully, the conversion of cortisone to cortisol is more robust and more in place in the elderly as compared to the youngsters. The second, of course, is the DHEAS. So there have been personal views, but we must understand that a good DHEA would mean better muscle mass, better bone mass, and DHEA replacement 25 ml per day has shown good responses in regards to general well-being, in regards to bone and lack of frailty. Now, as regards aldosterone, well, the aldosterone levels are reduced in the elderly. There is lack of synthesis. There is lack of passing out by the kidneys. And also, the cardiac muscle synthesizes some aldosterone. So, lack of aldosterone, if happens in isolation, it may cause hyperkalemia or hyponatremia. Hyponatremia may be really slow and the patient may not manifest unless in the extreme of stage. The adrenal medulla, the norepinephrine levels go down. However, the epinephrine levels are maintained, possibly because the cardiac muscle also synthesizes epinephrine. Testosterone. Now, it is interesting to note that andropause, which is now referred to as the late onset hypogonadism, starts in the age of 20 to 30 years of life. And there is a decline of 1% thereafter. We require at least 2 levels of testosterone to diagnose. So erectile dysfunction is the principal manifestation. The symptoms being tiredness, extreme sleepiness, weakness, irritability, erectile dysfunction, lack of muscle mass, osteoporosis. So how it happens? First of all, the total testosterone goes down because the GnRH is persistently high. It is not pulsatile, which means LH and FSH may rise. And also, the testosterone levels are low because the cells of Leydig, they become less responsive to LH. Second, with age, the SHBG that rises so that the proportion of free testosterone goes down and the total goes up. So free testosterone may be a better marker for a successful aging in the elderly as compared to total testosterone. So this is what happens in testosterone, a pictorial representation, and to your left is what happens once you start replacing. While replacing, be careful about liver functions, about hypertension, and about the prostate. What about the women? Now, in women, the average age of menopause we know is 51, and there is a steady decline. And two values of more than 35, some say more than 40 of FSH are required to label a female. The point of the matter is that low dose supplementation of estrogen might help the females. However, as Dr. Amit said, history of CA breast, CA endometrium, thromboembolic disorders are an absolute contraindication. Estrogen may also lead the liver to synthesize pro-inflammatory hepatokines, and therefore one has to be cautious. What about bone health? So bone health has many aspects to it, right from the GH, to estrogen, to DHEA, all of that, and now PTH. So secondary hyperparathyroidism is common in women and men alike. And the reason is, first of all, there may be a subclinical renal deficiency, which may trigger secondary hyperpara. And second, vitamin D deficiency. So as regards bone health, we know that the bones have FSH receptors there, and therefore, as the FSH rises, the osteoporosis incidence starts to rise. And once frank menopause ensues, we are well into the cascade of osteoporosis. So, a later menopause, a good vitamin D, and a good renal function may also be considered as successful determinants for aging. Diabetes, just a passing reference because diabetes in its own right merits a whole seminar. But suffice to say that diabetes may trigger neuropathy, which may trigger falls, nephropathy, secondary hyperparathyroidism, and of course, cardiac issues. Also, diabetes, as Dr. Paul brilliantly said, that it may cause a fallaciously high BMT. The adipokine, the adiponectin, thankfully, is higher in the elderly, and therefore it protects against the cardiac events. A word or two about ghrelin. So it increases food intake, adiposity, and body weight, maintains glucose. So the LEAP, the liver expressed protein, now that decreases GS secretion, decrease food intake. So anything which decreases the LEAP level may enhance ghrelin, food intake, adiposity, and body weight. So receptor antagonists have been used to good effect, although honestly speaking, I have no experience of all these. It's just through the literature that I came to know, and that's how it also helps us while presenting. So these are the antagonists, capromorelin, anamorelin, and morelin, which can be used. However, they are still in trial phase. So mental health, many people experience mild cognitive impairment. We all know that Alzheimer's disease has been roughly called as type 3 diabetes unofficially. And the reason is that there is insulin resistance at the level of brain also. So insulin resistance at that level may cause aging. So this is just a summary of what I was talking about, right from the adrenal to skin to bone to gonads. And then, of course, the somatotrophs, the GH, glucose homeostasis, and parathyroid. A word or two about pineal gland. So pineal calcifies with age. Pineal actually secretes melatonin, and with advancing age, the secretion of melatonin at night goes down, and therefore these people may have some difficulty in falling asleep at night. Garbaging. So this is garbage plus aging. The toxic products, cellular and molecular, they are disposed of by enzymes. But with aging, this this disposal is decreased and we get garbaging. The last slide here is on inflammating, so that once the garbage collects, it sets on intracellular inflammation, and this inflammation cascades into various tissues, which is known as the phenomenon of inflammaging. So to conclude, with longer lifespan, people are living older, resources are being used. But as Dr. Paul said, this is one age group which needs to be respected, loved, and cared for. There are certain hormones which could potentially signal the successful aging: a higher prolactin level, a higher DHA level, then somewhat normal growth hormone level, a higher adiponectin level, and of course, the lower PTH or PTH in the normal range. All of this could be a potential signal for endocrine determinants of successful aging. So the great basketball player Sachel Page, uh, who was actually a black, and he was often uh, junked for being a Negro. I'm sorry for that word, but that's what he was called for. And he would said, "How old would be if you didn't know how old you was." Thank you so much for your patient listening.